This is Dr. Anthony Chang coming to you from Southern California. Good morning, good afternoon, good evening, wherever you are. And this is another one of our AI Med Talks. And this morning I have a special guest, Dr. William Feaster, who is someone I have the privilege of working with on a day-to-day basis. So he's going to come on and talk about our transition to a different mode of healthcare delivery. Bill is our Chief Health Information Officer and very talented in the area of data as well as informatics. So Bill, welcome.
Oh, thank you, Anthony. I enjoy our partnership here at Chang.
Yeah. So the world's changed since just a few months ago. It seems like a year now. And you have the burden of assuring clinicians like myself at the hospital can still deliver healthcare and while staying at home. So how has the transition been for you personally and also on the institutional level?
Well, I no longer deliver care myself, so I've been able to work on the delivery side from a technology perspective rather than from the actual clinical care perspective. And it's been interesting changing work locations from the hospital to home, where I've been since Friday the 13th in March, when we went into social isolation for COVID. So there was quite an appeal for everyone to socially distance and to make sure that they weren't in contact with any more people than they had to be in contact with, and our patients took that very seriously too. And so our both our inpatient and our ambulatory visits plummeted. Our inpatient visits, by the time we got to Memorial Day in the United States at the end of May, had plummeted to half our normal volumes. Our clinic visits fairly quickly decreased to 30% or so of their normal volume. And our patients just weren't accessing care that they needed. So we needed to scramble pretty quickly to set up a way to deliver that care. Now, for the last 4 years, we've been trying to convince people and standing up technology to be able to deliver care through telemedicine or televisits into the patient's home. We've struggled getting adoption of that because no one seems to want to pay for it. They don't mind paying for it if the patient comes into another doctor's office and then we do a visit into that doctor's office, say a specialty visit, they're willing to pay for that. But if the patient doesn't want to go into anybody's office that wants to stay at home, no one really wanted to pay for that service. Well, a few things happened. First of all, with the pandemic, our CMS, which is Center of Medicaid and Medicare Services, relaxed the standards for telemedicine visits to include visits into the home, visits across state lines, visit with lots of different technologies, and many other relaxations that led us then rapidly expand what previously was kind of a nascent telemedicine program. We had hoped by the end of the year to have a total of about 500 telemedicine visits. That was our prior goal prior to COVID. In April and May, we did 20,000 telemedicine visits for both primary and specialty care. So it's a pretty rapid and pretty dramatic transformation. Now, what's interesting is that we've developed the technology. We have ways to do team visits if someone comes into a multi-specialty clinic. We have ways to extend out lots of good technology to people. We've developed all the infrastructure. And of course, now that people are relaxing their social distancing, they're feeling more comfortable, they're coming in for care. So primary care, the percent of televisits now is pretty much exclusively on sick visits because you can't do well with child care. with a telemedicine visit. It's kind of hard to give a injection, shot, jab, whatever you want to call it, depending on your
Yeah.
location
Yeah.
of an immunization over a visit. Virtual immunizations are too easy to do. I guess you could have people going to people's houses and do it, but that was one of our biggest problems, was primary care, and we were really worried that people weren't getting the care they needed, and particularly the immunizations that children needed. We're now back up to about 90%, as I mentioned, of actual in-person visits, about 10%
Yeah.
for sick care. So that's been quite a turnaround, but also a very appropriate one. Now, specialty care is still averaging about 20% of their visits on telemedicine. And I don't think that's going, just like primary care, I don't think this is going to change now, at least as much as we can predict at the moment, pending reimbursement. But we're trying to figure out what patients, instead of just everybody, what patients are the most appropriate patients for a
Yeah.
telemedicine visit versus an in-person visit.
Yeah.
So we still have some
Yeah.
challenges ahead of us.
Yeah. It's almost like telehealth visits have a hype cycle of its own, right? It's everyone wanted it when no one could get seen, and then it's going to settle to a happy medium somewhere. And I totally agree as a clinician that there's definitely a lot of patients I can see with a televisit, especially if the testing can be done locally as well. So a year from now, we have an effective vaccine. We're back to some semblance of pre-COVID days. Where do you think this is going to settle?
Well, I hope let's put it this way, where I hope it's going to settle is
Yeah.
about at its current level, because I think we've established a new norm where people, it's not, this isn't something that even the most senior of our physicians are now adapting well to this environment.
Yeah.
And they were forced to, or for their livelihood, but now they kind of like it.
Yeah.
It's we have to work on the efficiency. Sometimes having, we have to decide if, for example, during a day you're going to intersperse physical and televisits, or are you going to just do blocks of televisits? We've got to figure out the way we're going to move forward that works for everybody, patients, providers, staff, etc. And I think we'll figure that out over the next several months.
I put a vote in for having blocks. I think it's really hard to go back and forth. Timing wise, it's never perfect. So you're always keeping someone waiting, whereas as opposed to telehealth or just physical presence, it's rare that you keep someone waiting for a long time. So
the visit itself may not be that efficient either, because you got to have technical difficulties and this and that. So it tends to you need to appropriately. It's hard to run a busy clinic with a few telemedicine visits interspersed. And most of the visits are telemedicine. It's not a problem. So I think the biggest, everybody's healthcare system payment structure is different. Like in England with the National Health Service, I don't think it would be a big challenge to reimburse appropriately for televisit, because it's part of the normal payment to primary care providers. In the United States, where we're fee-for-service based, and we have government payers for both indigent patients as well as senior patients, as well as private insurance patients, as well as no insurance patients, it's going to be a little more complicated, because the insurers are already announcing that they're going to cut back on payments for in-home televisits. CMS, the government's indicating that the pandemic is going to be declared over. What a bunch of idiots, but the pandemic is going to be declared over towards the end of July. Or whenever, and maybe sooner, middle of July. If that happens and all the relaxations that have occurred suddenly disappear, telemedicine will suddenly be a problem to continue, or we'll have to find other method for funding. Like we've been funding a lot of our telemedicine visits right now through philanthropic funds. because payers aren't willing to pay for it.
Yeah.
So we were forced to, we can't expect providers to work for nothing. They have to be paid, and since our payment system is based on the productivity of the providers, we've got to do something to keep them whole, or they're not going to survive or not going to be available to us. So
well, I'm hoping that there'll be, go ahead. I'm hoping there'll be a happy medium and we take advantage of the technology that we were, as you said, forced to do. And I think everyone's experience, actually, at least my experience, been more positive than I expected in terms of getting the benefit of that visit. I clearly underestimated, even without testing, the impact on my patients and families just to have a televisit. So,
yeah, we've assessed satisfaction with the visits, and the patient satisfaction is very high. Top box satisfaction is about 90+%, 91%, I think it was recently measured, which is very high.
Wonderful.
I think the patients really appreciate the effort we went to accommodate their needs and the actual convenience of doing the visit. I think we're gonna, one of the things that we need to do is kind of track data from telemedicine, and we've developed a dashboard for lots of things. We've developed a quality dashboard, and we're going to look at things like, are people actually following through on their scheduled visits? Are they no-shows for that? What's happening to other clinic no-show rates? Are patients bouncing into the ED after a telemedicine visit, or are we keeping them out of the ED and treating them appropriately? So we have quite a few quality metrics, we have patient satisfaction metrics, and we want to make sure we're delivering a good service to patients. Another aspect is the technology itself, how we deliver that telemedicine visit. And there's tons of technologies out there that we could potentially have adopted or choose from.
I think also is bring into play the future of wearable technology as a complement to the service. But Dr. Bill Feaster, thank you so much for everything that you do for clinicians in general, and especially during this very difficult time. So thanks for being with us this morning.
Oh, you're very welcome, Anthony. Enjoyed it.